Hello, and thank you for listening. I'm going to talk today about the evidence-based, cost-sensitive infant formula algorithm that we developed for the Georgia WIC program to help determine what is the appropriate formulas for different infants, dependent on their status. I have numerous disclosures that are listed here, none of which are impactful on the algorithm here. In terms of optimal infant nutrition, breastfeeding is definitely best. The composition of breast milk serves as the basis for formula, but no matter what's done in terms of a formula that's developed, breast milk cannot possibly be duplicated. The whey casein ratios can be adjusted to be similar, but the whey and casein components are actually quite different in cow's milk and breast milk. The idea of formula manufacturers now is not just to be as close as possible to breast milk, but to duplicate the outcomes as well, particularly as evidenced by their attempting to get stooling similar to what a breastfed baby develops. So the indications, according to the American Academy of Pediatrics for infant formulas, is as a substitute or supplement for human milk in infants whose mothers choose not to breastfeed or are unable to do so exclusively. It's as a substitute for human milk in infants for whom breastfeeding is medically contraindicated, and as a supplement for breastfed infants who are not gaining adequate weight. However, I don't know if you've walked down the aisle at the grocery store and seen the various formulas that are there. They're taking a lot of shelf space and making it quite difficult to understand which are the appropriate formulas. If you look at any given brand, there's a half a dozen formulas that are all there, and yet the mother has to look at them carefully to decide. And when they come into my office, what I often find is that the parents will know the brand name, but they won't know specifically which one of the formulas that they're currently using. Additionally, there are boutique specialty formulas that are prescribed more often than one would expect, with a confusion or lack of understanding of the additives by both the families that are using them and the physicians who are prescribing them. So we developed the infant formula algorithm, and in doing so, when I include we, I'd like to acknowledge Colic involvement as well. We looked at these and decided that the formula prescription should be medically indicated. The decision should not be manufacturer-based. We wanted to decrease the parental influence in terms of them coming in and requesting the formula. And we wanted it to be very much evidence-based, recognizing that specialty formulas are used much more often than we would expect. We wanted to provide guidance not only for the healthy term infant, but for the preterm infant, and for those who are suffering from individual problems such as colic and irritability, allergies, malabsorption, or decreased weight gain. We also noted that lactose-reduced formulas are not covered because of the extremely low incidence of true lactose intolerance in infants. They may be somewhat sensitive to that, but they are not truly lactose intolerant, or at least it's extremely rare in this country. We therefore were cost sensitive. There is such a difference in the cost between the routine cow's milk-based formula and the specialty formulas. For these approved formulas, this is not just trivial. It actually is a difference between $150 and $500 per month for a single infant consuming approximately a quart of infant formula on a daily basis. When you bring in WIC subsidies, that difference is even greater in terms of the cost to the WIC program. We have been credited, frankly, with saving the WIC program $52 million in savings. And since the algorithm has been adopted, the decrease in non-formulary use has dramatically dropped down to just simply 1%. On this slide, what you can see is that there is this distinction between those that we consider tier 1 formulas, which is the routine formulas, and those that extend down to the formulas we would use for problems, and then where the problems become much more extensive. As you can see, the amino acid formulas can cost as much as $500 a month. The tier 1 formulas are $150 a month, but breastfeeding is essentially free, with the exception that it costs $4.80 monthly for 1 milliliter a day of vitamin D supplementation. With WIC as a supplemental formula for the 6 to 11-month-old, the formula is given at 21 ounces per day. What that means is that they're expected to be using solids to make up much of the difference, but for infants who are hungrier and get more formula, that WIC participant will have to buy formula, and so this cost-effective formula must be beneficial for them as well. This is a depiction of the entire formula algorithm, walking the physician and provider through what's there for the term infant, and then for the various problems that can exist for the infant. And as we go through this, you will see we'll break it down into each individual section. For the preterm infant, we're talking about a very similar algorithm where breast milk is, in fact, the preferred substance to be supplemented with human milk fortifier until they're discharged from the hospital, and then to continue. If they are supplementing or not breastfeeding, then we look at the premature infant's formula in the hospital-based child who is pre-discharge, and then that goes on to what's called a transitional formula, which moves from a 24 calorie per ounce to a 22 calorie per ounce formula that they will use. Now, hopefully they'll do wonderfully well on that, and they'll stay on that for 6 months plus the amount of time that they were premature. So for a child who was a 32-week gestation baby, that means that they were 8 weeks premature, or approximately 2 months premature, and therefore they will be on 6 months of this formula, plus the other 2, making them stay on it till approximately 8 months. However, if that child is having one of the other conditions that requires change, they should go to that formula instead. If we look at the tier 1 infant formula, then we're talking about what's called a routine cow's milk-based protein formula. That's currently this Nestle Gentle formulas in this algorithm, though it is partially hydrolyzed whey protein. If they are going to breastfeed or not breastfeed is then a determination, and they would go on to that formula. If, on the other hand, they develop a problem, that's when we start to sort through these tier 2 infant formulas. Let's start with the child who has gastroesophageal reflux. Reflux, as you know, is simply regurgitation with the upward movement of the stomach contents, including the acid as well as the formula, into the esophagus and sometimes out of the mouth. So most of these babies are spitting, and often they're happy spitters, but concern arises when they have other problems as well. And then it goes from gastroesophageal reflux to gastroesophageal reflux disease. These infants are having either weight loss, failure to thrive, feeding difficulties, intermittent torticollis where they're turning their head, which is often called Sandifer syndrome, or they're having respiratory symptoms because the refluxate, what's coming up, is either spilling over into their lungs or coming up and stimulating the vagal nerve, which is causing wheezing. There is a concern when these babies are having these problems, and they often go on to acid blockers. The acid blockers are fine in terms of their use, but they've been shown not to be very effective. Instead, what we find is that a rice starch formula is often useful. It is not currently covered on WIC, however. So when a rice starch formula cannot be used, or is being, or the WIC population is being considered, then we add cereal to the formula, usually at approximately 1 teaspoon per ounce to start. However, with that, you also have to realize that you're adding 5 calories for every ounce, so that that child who is getting a 4-ounce feeding is getting an additional 20 calories in that feeding alone. That adds up over time. Now, that may reverse the issue of weight loss, but it also can contribute to a considerable amount of weight gain for the child who is otherwise healthy and doing well and spitting up very little of the formula and not losing weight. A second consideration is the child who is irritable, or as defined as colic. Colic is an inconsolable irritability that comes for a period of approximately 2 to 4 hours a day between 3 weeks and 4 months of age. When that irritability is more prolonged, meaning throughout the day, or it lasts longer than that period of time, other conditions have to be considered. It may in fact represent that that child's irritability is due to allergies, gastroesophageal reflux, or infection. It can also be something that's a non-GI cause, such as neurological disorders, or difficulty feeding, or even a urinary tract infection. And so what we often see with this child who's excessively crying is that there can be multiple problems with dairy or soy intolerance, neurological impairment, or reflux, as well as colic. With that child, the first choice would be to go onto a soy formula. If that doesn't work, the child would then be considered possibly having soy allergy, and that needs to be determined, with soy intolerance as a second possibility. The choice then would be then to move on to a casein hydrolysate, and if the child is improved, to stay on that formula, either the soy formula or the casein hydrolysate, till at least 6 months of age, at which point the mild infant would be switched to the routine formula, or if they're having more significant problems, they would stay on it till approximately a year of age and then be reevaluated. If, on the other hand, they don't do well on the casein hydrolysate either, they would move on to an amino acid or elemental formula that is associated with a significant evaluation at that point. Because of the expense of that more complex formula, we usually recommend that these children get well evaluated by a pediatric gastroenterologist or someone who is very familiar with these conditions. An allergist might be able to do so as well. That does indeed bring up milk protein allergy. It can come with a rash, which is recognized as either eczema or atopic dermatitis. There can be wheezing, vomiting, and or cough that's present. Now, what's of note is that approximately 10 to 14% of infants with cow's milk allergy will have a true IgE-mediated allergy to soy as well. Those who have non-IgE reactions to milk may have a 40% cross-reactivity to soy. Thus, that means that somewhere between 60 to 86% of the babies who don't tolerate cow's milk protein may be able to tolerate soy. And that's why that can be used. And with the fact that soy is much less expensive than a casein hydrolysate, in this cost-based evidence-based algorithm, it makes most sense to consider soy as the next formula as option. When do you suspect a protein allergy? When there's a family history, when there are the symptoms that we discussed, with the atopic dermatitis representing 50 to 70% of those patients, the respiratory patients having 20 to 30% of this population of allergy, and then the GI allergy issues often being much greater, with reflux or regurgitation in 42%, stool irregularities with diarrhea as much as 50 to 60%, and we'll talk about blood in the stool shortly. The child who's not gaining weight is approximately 25% of this population, and the irritability is seen in 27% of this population and is not independent of these others, but often seen in conjunction with it. With the symptoms of atopic dermatitis, you'll see this rash. You'll also see a great deal of itching, skin dryness, excoriations, and irritability. And that severe atopic dermatitis is often associated with food hypersensitivity and looks like just patchy areas either on the face, on the back, or I saw a child today where it was diffusely over the entire skin surface, and that child had even lost hair with it as well. When we start to see bloody diarrhea, these are patients that it can be painless. There's lymphoid hyperplasia in the colon, and you'll get an eosinophilic colitis or an allergic proctitis that on the right side of this slide is demonstrated with lymphoid hyperplasia that's seen and can be seen with infiltration into the lamina propria and tissues of the colon. Even in breast milk, there can be allergies that require dietary change for the mother, with cow's milk and soy-derived protein that may need to be eliminated from the mother's diet. They are present in many products, and so we try to get the patients to avoid not only the intact milk, but also casein and whey. So there's an entire list here for the foods that the mother may need to look at in terms of eliminating from her diet if she's breastfeeding. In terms of the infant, we again want to eliminate the issues where there may be an allergenic source, and we go from the most allergenic, that being dairy and soy, to the hydrolysates, where the protein is broken down into small pieces, and the amino acid formulas, where there are just amino acids, and these are well tolerated and also considered very hypoallergenic. So in the infant who is having this milk protein allergy, again, we would consider soy, but often move quickly to a casein hydrolysate, and from there to an elemental diet if that's necessary. The other consideration that's similar to the situation where the infant's demonstrating evidence of allergy is when there is a strong family history of allergy with evidence of atopy in the first-degree relatives. In there, we know that elimination of a cow's milk formula with the use of an extensively hydrolyzed formula may lessen the development of atopic dermatitis and childhood food allergies. An extensively hydrolyzed casein formula may be employed instead of or after a soy trial. This is an area of controversy because of the question of whether there's a much higher incidence of further allergies that may develop much later. The question isn't answered yet and needs considerable research to look at it. But we do know that if both parents have an allergy, which is only 5% of the situation, the potential for food allergy is as great as 50 to 80%. If it's one parent or a sibling, that's 40 to 20%. With neither parent having an allergy, there's only a risk of having allergy in approximately 15% of those patients, and it's probably even less than that, with the estimates even going down to less than 5%. But one we also have to remember is that 55% of those who have an allergy incidence, the parents do not have an atopic history. So you want to sort that out very carefully before going to these more expensive formulas that may or may not be necessary for these children. We then start to look at this population that we talk about with GI bleeding. The first thing that should be done, of course, is to make sure that there's not an infection that's provoking that, where there's a considerable amount of diarrhea. If there's not diarrhea present, this can be a result of the infant formula or the food or a food in the mother's diet if she is breastfeeding. And it's usually milk or dairy products. This can be a very significant problem and life-threatening, particularly if vomiting occurs at the same time. And in that situation, it's what's often known as FPIES, or food protein-induced enterocolitis syndrome, where milk is often the offending agent, and there's a great cross-reactivity to soy of as much as 64%. And that automatically means that you don't want to go on to soy formula as your first choice, because the extensively hydrolyzed casein formula then becomes much more attractive, because the 46% chance of not having soy as an offending agent is much less in this situation, and casein then seems to be eliminated as well as the soy. As we move down through it, you can use soy if you think that that's really a rare situation, but a better choice may well be the casein hydrolysate. And then again, moving through the same algorithm, we know that if there's no response, as you eliminate the casein hydrolysate, you move on to the elemental formula. Malabsorption is a different issue. This is when there is only partially digested fat in the stool, and there is weight loss, a lack of weight gain, and failure to thrive. Changing the formula rarely works in and of itself unless there's a true fat malabsorption. Sometimes if there's failure to thrive, you can simply increase the formula density to increase the calories, and the child will do well. If that's not the case, one wants to move on to one of the formulas that contain increased medium-chain triglycerides because they're well absorbed. This presence of failure to thrive certainly deserves further attention, because it can often implicate other factors or conditions that need to be evaluated. And again, if this child is not responding, an amino acid formula may be indicated. So we move through the condition that's seen here on the right, where we first increase the caloric density, and we do so by increasing the amount of powder in relationship to the normal water that's added in the powdered formulas. We then evaluate further if this is the case and not responding, and usually look at an extensively hydrolyzed formula with medium-chain triglycerides, and from there go on to the amino acid formula. In all of these situations where any formula is used, again, if the child is mild, we find that they usually respond after 6 months. If they're not doing well, then we continue on for a year. What we see is at 6 months, there's what's called gut closure, from the work of Alan Walker and colleagues up at Mass General, where the cells knit together and there's less passage of antigens and less of a problem that will exist. Again, if they're not responding, then we have to continue out to a year and then get reevaluated if they are having any point of issue at a year of age. With the preterm infant, we've already discussed this situation, understanding that human milk fortifiers generally are needed with the breastfed infant, and that they should go on through the premature and transitional formulas as they are in the hospital, and then upon discharge, going on and staying on those for the indicated amount of time, and going on to the other specialty formulas as needed for situations that are including allergy, blood in the stool, reflux, or family history of allergy. There are additional resources that are available if you have any questions. You can see those through the special edition of the Georgia Chapter AAP, which is on their website. There's the poster that is available that shows that algorithm in more detail. There is an accompanying book that was written in 2013 and published that goes through this for the parents to help them understand the situation as well. It also helps them understand when to look at introducing solids and when to look at situations of either their child who's continuing to have difficulty gaining weight or their infant who is gaining too much weight. And there are additional resources here on nutritionforkids.com. Thank you very much for listening and watching. It's been a pleasure.